you, everybody, for joining the second of our Canadian Health Workforce Network Research Priority Dialogues. This is such an important conversation we're having. We're joining from coast to coast to coast, and we want to acknowledge that we are gathered on territory of First Nations, Inuit, and Métis, and extend respect to Indigenous peoples on this land we call Canada, for their valuable past and present contributions to this land, and for the ability to work, play, and live as guests on this land. And we acknowledge that such land acknowledgements or Indigenous affirmations are only one small part of dismantling, disrupting Indigenous erasure and colonial structures, which in healthcare and health workforce is quite specific. I'm situated in Ottawa, the traditional unceded and surrendered territory of the Algonquin and Anishinaabe people, and thank them for that ability to be here. So just by way of overview, just going to give you a little bit of background about who we are at CHWN, all of our different members and leads and partners. I'll give you a bit of an overview of recent Canadian health workforce reports, and by recent, in the last year. An overview of the Canadian health workforce literature landscape based on work that we've been gathering for the last 10 years or so at the Canadian Health Workforce Network. And we're very, very pleased to be joined by representatives from the Institute for Health Services and Policy Research at CIHR, folks from SHRC who have joined in some of those initiatives, and colleagues at the Canadian Institute of Health Information. So we have many colleagues here from CIHR, and we'll have presentations. So just by way of who we are at the Canadian Health Workforce Network. We are a network around health workforce. We're internationally recognized researchers based all across Canada. Collectively, we've been doing decades of health workforce research, and we have national and international academic partnerships. We are world-class conveners of network stakeholders, so really bringing people together. And by say world-class, folks from the UK and the US often engage with us to look at the approach that we have done with creating the Canadian Health Workforce Network. We're experienced knowledge mobilizers, getting information into the hands of decision makers that need to make decisions based on the research that has been undertaken, and providers of innovative evidence-based solutions to complex health workforce challenges. So really trying to work in this space. Our areas of strength and expertise and our partnerships cut across the following key themes and across these key sectors. We're more than happy to embellish these if someone would like to take a lead on that. So our themes are equity, diversity, inclusion, governance and regulation, health workforce data, particularly for planning, healthy work environments to support retention, integrated care models optimizing scope of practice, and mobility, migration, and integration. And we'll be discussing 3 of the themes today. And across the following sectors: care across the life course, primary care, which we'll discuss today, sexual and reproductive health care, including maternity care, we discussed on Friday, as well as mental health and substance use health workforce. So as mentioned, our team brings decades of collective experience across Canada. So Neera Gupta is our lead for equity, diversity, inclusion. Kathleen Leslie for governance and regulation. Sarah Simpkin and Dax Bercier co-lead around health workforce planning. Arthur Sweetman for health workforce data. Gail Hallis around integrated care models, optimizing scope. Brenda Gamble around healthy work environments, supporting retention. And Margaret Walton Roberts, mobility and migration. And these are just some of the universities that they represent. Our sector leads also bring excellent experience audit report around care across the life course. Catherine Zagrodny co-leads with Audrey on this initiative. Maria Matthews and Lindsay Hedden for primary care. Carolyn Chamberlain-Rowe on sexual and reproductive health care and maternity care. Mary Bartram for mental and substance use health workforce issues. And I'm very pleased to be working with all of these amazing, wonderful people as a lead. So I'm going to move now into what we could call an overdiagnosis problem around health workforce reports galore. And this is just a depiction of the reports that have been published since May of 2022 to April 2023. So lots of them. So it started off around a stakeholder dialogue that was held by, or sponsored by Health Canada, undertaken by KPMG. And it was a What We Heard report. And that report really informs the Coalition for Action on Health Workers that was announced in November of last year. Other reports, sort of a micro report from the C.D. Howe Institute with folks from Queens, which is calling the shots on health workforce, which really focused on planning. The Canadian College of Health Leaders and Healthcare Can had a dialogue at their National Health Leadership Conference and produced a report called A Call to Action to Creating Meaningful and Sustainable Change for Canada's Healthcare Workforce. The two reports at the bottom of the screen focused really on the nursing workforce, which is the largest of our health workforces. The Royal Society Investing in Canada's Nursing Workforce, which was prepared in May 2022, and a report that was commissioned by the Canadian Federation of Nurses Unions with the Canadian Health Workforce Network, led by one of our colleagues here, Hussam, looking at sustaining nursing in Canada, Canada's health workforce. That was released in November of 2022. The three reports in early 2023, first of all, the House of Commons Standing Committee on Health. So they held a lot of dialogues, accepted, reports and witness statements on addressing Canada's health workforce crisis. And so that was released in March of 2023. The CMA Foundation commissioned a report through the McMaster Forum, the last of which was prepared in March 2023, but I think that there has been an update. And then the Canadian Academy of Health Sciences produced a report in 2023, which was focused on a number of questions and posed by the funders of the report, Health Canada. And that's Canada's Health Workforce Pathways Forward. So in brief, these reports cover very similar topics, which speaks to the consistency in the diagnosis problem. I think the reports are quieter on where to go next with some notable exceptions. So I think HESA and the Canadian Academy of Health Sciences report focus on that. I just wanted to announce so that everybody knows about this, that in February, for the federal government announcements, they did announce a Center for Excellence in Health Workforce data as part of the budget. And so it was confirmed also in the budget. And our colleague Deborah Cohen from CIHR can speak to some of the issues in regards to the Center for Excellence. All right, moving to the Canadian Academy of Health Sciences report. I wanted to make a specific mention of the CAS report because it forms the basis for the CIHR Institute for Health System Policy Research call that the Social Sciences and Humanities Research Council has joined. So it's important to note that this report was commissioned to create evidence-informed pathways for action, and it wasn't necessarily a gaps analysis. And it's important to note that these are very important areas, and they do map onto the thematic and sector foci of the Canadian Health Workforce Network. But what was really telling is the Canadian Academy of Health Sciences undertook a review of reviews and was international in scope. And what was sobering was for us to realize that 3% of the reviews included articles that were undertaken in the Canadian context. So I think it's really important to take note of that. And so one of the reasons why we wanted to do this dialogue and also to share insights from reviews that we have undertaken by the Canadian Health Workforce Network library is because I think that it speaks to some of the important gaps that we really want to hear from you. So if you're not familiar with the Canadian Health Workforce Network library, it's a library of both published and gray literature. It goes back to 2000, but there are also some Sentinel reports in there. There are right now over 8,000 sources. If you go onto the library, you can search by author, by year, by theme and topic, and advanced search. And we have created an Excel file, which has formed the basis for some of the charts that we are going to show you. We're just going to show you the ones for the past 5 years, but there will be data that we're going to be pulling together that goes back further than that. If you go into the CHWN library and you find that your article or your report is not in there, please send it to us. We're happy to include that. And that just makes it a more robust resource. So based on an analysis of the library sources, we looked at articles, again, published between 2018 and 2023. We only have a partial year for 2023. So this is 1,667 sources. And this is by theme and by year. And so you can see that there are some themes that are very well worn. Healthy work environments, models and scopes, and these are ones that we discussed on Friday. And you can see that others are smaller, and you can see the yearly distribution. So each of the breakouts will provide you with a little bit more detail for each of these specific areas. So on Friday, Kate and Brenda and Gail discussed regulation, healthy work environments, models and scope. And today I'm going to walk through on behalf of Niru about equity, diversity, inclusion. Arthur is going to cover health workforce data and planning, and this literature does overlap quite a bit. And Margaret is going to lead a discussion on mobility, migration, and integration. We mentioned 2 additional groups here, leadership and technology, because they are sort of emerging cross-cutting issues, and happy to look at those separately. So if you have some ideas that cut across leadership and technology, let us know. We do have sort of an additional bucket where we can put some of those. If we look at the 4 sectors of focus, and again, the CHWN library covers many, many more sectors than these, but this is where we have leadership. You can see that sexual reproductive health, maternal child care, much smaller than mental health, primary care, community, and long-term care. We've combined those, so that's home, community, long-term care are combined. And again, each of these breakout groups will discuss those. So Mary and I discussed the maternal child care and mental health on Friday, and Lindsay and Catherine will take us through the primary care, long-term care discussions. So other overview slides in regards to the library is that qualitative research and interviews and surveys that are researcher generated are what predominate. And I point out issues around sort of databases because this is an area where we could optimize the use of existing databases and where databases could be optimized for research, and which is the reason why a Center of Excellence is so timely. And so really great to have Deborah here to speak to that. When you look at this type of methodology as a field, it really means that we're still in that developmental phase and a descriptive phase, and we really want to accelerate that. There should be much more balance for there to be like a robust, field of inquiry, a field of science. We would expect that there would be a more balanced nature here. This will probably be not surprising to folks in terms of the predominance of nursing and medicine. And in fact, they are, the largest professions. But what's very interesting is that managers, administrators are sort of the 3rd largest groups, which kind of speaks to the issue of, discussing a theme around leadership. Other healthcare workers, which is kind of where we've coded for multiple health workers, and so we're going to precise some of these before we publish it. And so this is all that I could fit on the slide. So if you do not see your health worker group there, it doesn't mean that you don't have anything in the library. It just may be in a small capacity. So again, please share your resources with us so that we can add that. So with that, I really do want to pass over to Rick from CIHR, and then which will be followed by Éric Bastien from SHRC and Deborah Cohen from CIHR. So I'm just going to stop sharing and pass over to Rick.
Okay, thanks very much, Ivy. We'll get our slides up, and while we're doing that, I want to thank you, Ivy, and the Canadian Health Workforce Network for first of all, organizing these two sessions on research priorities, and also for providing us with the opportunity to talk to you and to present on a new funding opportunity that we think will be of interest, and just generally what we've been doing at CHR in this area, leading into partnerships, and very delighted and thrilled to have our important partners on the call this morning as well. I want to acknowledge the presence and contribution of Jessica Nadeville, Associate Scientific Director of the Institute of Health Services and Policy Research, who's here with me today, and I believe running slides. Thank you, Jess. So next slide, please. The Canadian context, I think people are pretty much familiar with. Just a few kind of major issues to raise. And that is pre-pandemic, which is Exhibit 1 on the top left, which is the Commonwealth Fund International Health Policy Survey. Pre-pandemic put Canada in relation to 10 other countries that are routinely surveyed in this work, very near the bottom with the US. US ranking 11 at the bottom, Canada ranking 10th, which means close to the bottom with the US in overall rankings. And countries that are fairly similar to us in demographics and geography and so on, like Australia, ranking much, much higher. You can see that the lowest rankings here are on access to care and equity and health outcomes, driven largely by our long waiting list, lack of access to care, and the equity piece is around lack of funding of pharmaceuticals, dental care, eye care, rehabilitation, and so on, that many other countries fund. So we started off pre-pandemic in not a world leader in health system performance. And if we look at, if we go down on this page and we look at what are the numbers of physicians, nurses, what do the demographics look like, there are a lot of healthcare providers, but the demographics have changed a lot, and our workforce is aging. 14% of Canadians are attached to a family doctor, for example, over the age of 65. So that's a very concerning statistic. About 6.6 million Canadians do not have access to any form of ongoing relationship-based primary care. We know urban, rural, north, south, and many other kinds of maldistributions and disparities exist. For example, in rural areas, almost 20% of Canadians live in rural and remote areas, with only 8% of physicians and roughly 12% of nurses. We know the health workforce is an enormous contributor to employment in Canada at more than 10%, to the health budget at more than $175 billion annually, to GDP at roughly 8%. And yet, if we look at the top right and we look at CHR's investment, so the circle here represents the health services and policy research investment of about $931 million over the last 10 or 11 years, of which only about 80 million, 79.7, or about 8.5% was dedicated to health human resource. And if we look at the entire CHR budget, which is over $1 billion a year, and therefore about $11.8 billion over this period of time, health human resource represents less than 1%. So we have a giant disconnect between the role and importance of the health workforce and the research attention that has been drawn to this really key issue. And we now know we're in the midst of a workforce crisis that calls for better data, better research, better evidence, better decision making, and changes in policy about how the workforce is recruited, supported, engaged, and so on. Next slide, please. So what have we been doing at CHR? So the one I'm going to focus on today is called Strengthening the Health Workforce for System Transformation. It's labeled here as longer term. I would consider it more medium to longer term, because we've actually just launched it and it will be funded around this time next year with an application deadline in November of 2023, so coming up. But in the short term, we had lots of discussion with our federal health portfolio colleagues at Health Canada and elsewhere. Enormous interest across provinces and territories as the health system has come under such huge strain. And in the short term, we mounted a best brains exchange last October with the workforce leaders across federal, provincial, territorial jurisdictions. We launched one-year Catalyst grants, funded 29 teams in these Catalyst grants. And then most recently, we funded 1-year planning grants and funded 12 teams. This was in partnership with Health Research BC. And these planning grants were really meant to help prepare teams for the application for the Strengthening Health Workforce for System Transformation grants that will be this fall. Of course, they can help them plan for project grants or provincial or other funding opportunities as well. The other thing that we did is we had, at the time we were speaking to Health Canada last summer, we had the policy research for health system transformation grants open. There'd already been a call, it had already been launched. The deadline, application deadline, was still a ways away, and we were able to add a pool that we funded internally at CHR across institutes and initiatives for an additional number of workforce focused, health human resource focused grants. We ended up funding 60 grants, 29 of which ended up being focused on health human resource. So this is really important in the policy realm around all of the policy landscape and policy options to help support workforce in all of its various ways that you've heard earlier from Ivy. So we'll move to the next slide, and I'll talk about the strengthening workforce for health system transformation. We did hold a workshop just yesterday, and we hope that some of you were able to make it to that workshop to hear more about the details. The slide deck in English and in French and a Q&A will be available through the CIHR contact center shortly. So it's not available right yet, but it will be within the next week or so. So the idea here for this this new call is around producing new evidence, building capacity, sparking collaborations, and fostering knowledge mobilization and impact. This call, as Ivy mentioned, is aligned with the Canadian Academy of Health Sciences pillars, and we purposely kind of aligned with that that thinking and that report. Next slide, please. Of course, so of course we don't do this alone. So we've done this with a lot of partners. You'll see the details of all the partners on the next slide, but you can see that kind of how this is all manifested in the different funding pools. So there are 9 different funding pools, and there's also an evidence support and knowledge mobilization hub that one of the funded teams, and at the application process, they'll have the option for submitting, I believe, Jess, it's a 2-page proposal for also being funded separately and additionally to support the hub that will run across all of the teams. So if you look at the pools and there are various numbers of grants from 1 to 4 in each of these pools, there's what's called a general pool, or the Institute of Health Services and Policy Research, or ISPR pool, which is open. There's an Indigenous health workforce pool, public health workforce, rural and remote workforce, pediatric health workforce, equitable, diverse, and inclusive health workforce, cancer health workforce, and an aging, 2 really interesting one around the workforce that cares for an aging population, and the other is aging workforce, that the workforce itself is aging, as I alluded to earlier, and how do we support people at that stage of their career. Next slide, please. Oh, and I'll just say, sorry, just going back to the previous slide, I'll just say that applicants are able to select up to 3 of these areas on their application. We know these are not mutually exclusive. Applicants do not have to select the general pool. That will be automatic. The IHSPR open pool will be automatic, and they can select up to 3 additional areas, because we know that rural and remote can overlap with Indigenous, can overlap with aging workforce, et cetera, et cetera. So we know that these things are not exclusive to each other, and people can select up to 3 areas in addition to the default general area. Next slide, please. So again, I want to just the profile here is that these are 3-year grants, the $250,000 per year for a total funding of $750,000. The hub will be funded for an additional, so one of the teams that's funded will have an additional $375,000 for the hub. The total funding is $11.3 million to support 14 implementation science team grants and 1 hub. The information webinar, as I mentioned, was yesterday, and some of those materials will be available soon for those who are not able to make it. Registration deadline, October 5th, application deadline, November 9th. notice of decision about and start date coming around this time, late May, early June next year. There also is a rapid response capacity that's being built into these grants because of the delay. It takes a long time, of course, to do peer review and to give the community time to respond. And we launched the planning grants as well. So we know that there's a long lead up to what is happening inside a crisis. And so these teams will all have some rapid response function as well. At this point, as we hand over to SHRC, I really want to thank and congratulate the Social Sciences and Humanities Research Council for their tremendous partnership on this funding opportunity and on many other things that we do together. The Michael Smith Health Research BC, and many of the other institutes and initiatives at CHR, including the Institute of Aging, the Institute of Cancer Research, the Institute of Human Development, Child and Youth Health, the Institute of Population and Public Health, and the Center for Research on Pandemic Preparedness and Health Emergencies. So I will say that we could not launch major initiatives like this on our own, and we are very indebted to and very grateful for and really love working with our partners inside CHR, inside the Tri-Council, and also across the country. I think that's pretty much it, and probably a really nice segue for SHRC, who are next.
That is super. Thank you so much, Rick. And I think that we have regrets from Éric today. He was able to join us on Friday and speak to the importance of the initiatives that they are supporting on equity, diversity, inclusion for SHRC. And it really is wonderful to see a partnership. Many of us who are part of the Canadian Health Workforce Network identify as social scientists. And so that is really wonderful, and really would like to see more of that going forward. Absolutely. So with that, we will pass over to Deborah Cohen from the Canadian Institute of Health Information. Deborah, please.
Thanks so much, Ivy. Thank you very much for the invitation to come today. I was at the session last week, and I have to say it was excellent and so inspiring to hear the ideas that were generated on the first set of buckets. And so I'm looking forward to today. I wanted to just take a few minutes to give folks an update on the Center of Excellence that Ivy mentioned. So in February, the federal government announced the standing up of a Center of Excellence for HHR, with words to the effect that CIHR will be assisting in standing up this organization or this entity, whatever it's going to be. It's really only been since about April that conversations at the very senior levels have been happening. And the punchline here is that they remain very much at that senior political level: negotiations, funding, leadership, governance. So all of that's still happening over there in sort of at a higher level. But one of the things that is, become incredibly obvious is that the HHR crisis is right now. And we don't really have the privilege of time to wait for all of the dust to settle. It will come when it comes. But in the meantime, we need to be talking to each other about what are the actual problems that a Center of Excellence for HHR data and planning are trying to solve. Because if we can actually agree on the problem space, there is a hope that we'll be able to actually find common solutions that everyone can agree to. And so we're at the very early stages of conversations, and more to come. I'd love to have a conversation, for example, with this group here to talk about that problem space as well. But as the problems are starting to emerge, I'll just share back with you what I'm hearing so far, and they're sort of in themes. The first one that is uncontested, that is, everyone can agree on no matter where you're from, is that we need to do better at data. We have a data infrastructure investment problem in this country and have had so for the last 20 or 25 years. And that data that we need to do better at involves not just supply information for health workers, but we need to think more creatively about education data, immigration data, payroll data, and the list goes on and on. And the ability to connect that HHR data to the population health data and clinical services data, so that when we start thinking about forecasting and needs, we're not doing HHR in isolation, we're doing it as part of the population profile that's required to get the right people at the right place at the right time. So that's the data side. In addition to the data, it's pretty clear that data for data's sake is actually not a good investment. We need to do better at common metrics and measures, forecasting tools, putting those methodologies on top of the data. Think about national unique identifiers. We've been working on that one for 25 years, FTE methodologies and so on, that make the data useful. So that's the first bucket. The second bucket is a recognition that as a country, we're really not very good at connecting the data landscape to the planning landscape. And that's in part because we are lacking data literacy in many aspects. And in other aspects, we're lacking planning literacy. And so we need some kind of strategy that allows for bidirectional influence between those two things, so that the data is actually informing the planning agenda. But the planning agenda and the priorities for, the actual where the levers happen for implementation are actually informing the data that we need to collect. So there's work to be done there and creating a machine that allows that to happen. The next one is quite a profound network of networks that exists in this country around HHR. The CHWN is an excellent example of an exceptional network that exists in this country, of a group of people who truly are rallying around and have rallied around HHR, whether or not it's in vogue or outside of that, right? So as the policy interest comes and goes, CHWN has stayed fast and true to an interest in HHR, and that is powerful stuff. There are a lot of other networks in this country that are interested in HHR and probably would put up their hand and say that's their primary purpose as well. And we need to do better as a country of connecting our network of networks, because really what we're seeing through the pandemic is every organization has, in a very well-intentioned way, attempted, according to their own mandates and objectives, to solve the HHR crisis through their lens. And what it's not done is allowed Canada writ large to harness the total power of our network of networks, so that with a North Star, we're all rowing in the same direction according to our own collective mandates and objectives. And the last one that has emerged time and time again is the fact that HHR is not a provincial crisis, it's not a national crisis, it's an international crisis. And we have to be very thoughtful as a country about how we recruit ethically, but also how we work with other countries in leading and learning as a partner, as we start to figure out where do we go to resolve the HHR crisis and to allow ourselves to be in a better position 20 years from now, so that we're not in crisis when the next pandemic comes along. Those are the big themes that have emerged. And I want to say there are two other truths that have sort of emerged through all of this, which are not even themes, they're just truths. And the first is, we need to remember the whole reason we have a healthcare system and we have health workers providing care is because ultimately the goal is to provide the best quality care to our patients. And we are among them. All Canadians deserve that care. So we need to keep in mind that patients and their voices are critical to this dialogue and discussion. But the other fundamental truth here is that the health worker needs to be at the center of all of this. Not one profession, but all of the professions, because every profession in this space is the reason we have a healthcare system in the country. Health, human resources are healthcare. And if we don't put HHR at the center of the solution, we haven't really found our sweet spot. So all of that to say, these are the messages that are emerging. Now, the last comment I want to make is this. As we're starting to move forward in exciting ways to see investments in data and in planning, in policy and implementation, and in evaluation, the one through line that crosses through all of this is that research has to support all of them. And that is why it's so important to hear from your voices about all of these different topic areas that you've identified, because these are where the research will rise up and support that continuum as we continue to get better as a country. So I look forward to today. Thanks again, Ivy, for the invite. And I look forward to speaking with you all in the future. Thanks.
Great. Thank you so much, Deborah. And it's wonderful to have CIHR as a partner, intricately connected with this. And with that, I just wanted to acknowledge Éric Bastien from Social Sciences and Humanities Research Council has joined us. And so I want to give Éric some opportunity to speak from a social science perspective, the importance. Great. Thanks, Éric. Go ahead.
Thank you, Dr. Bourgault. I just want to say that SHRC is pleased to join CIHR for this this initiative. Sorry, we're happy to contribute funding to support one project around the area of EDI, equity, diversity, and inclusion. So our idea, our purpose to join this initiative is really to attract perhaps some new researchers in the social sciences and humanities that have not perhaps worked in the health domain before, and to join a team of experts in health and to perhaps contribute some of their research outcomes in the past, or contribute some best practices that they perhaps have learned from other sectors outside of health that could be helpful for the health sector. So really trying to build interdisciplinary teams there. So very happy on behalf of SHRC, thank you to CIHR and Dr. Glazier to reach out to SHRC and for us to have the opportunity to contribute to such an important initiative. So I won't take much more of your time. So thank you again, Dr. Bourgault, for allowing me this time. Thank you.
Thank you. Thank you so much, Eric. And yeah, very, very helpful. I speak on behalf of many in the health workforce field who identify social scientists. We're really very pleased to have SHRC join us. So thank you to all of our presenters. I hope that's whet your appetite. I can see people starting to interact in the chat. That is absolutely wonderful. This is what we want to do. So I'm going to pass over to our facilitator extraordinaire, Eric, who is going to walk us through what it is that we're going to be discussing. So just letting everybody know, you identified your number one, number two areas. And Audrey has been working feverishly behind the scenes to assign everybody to a group. So we'll have breakout groups that will have a CHWN lead and a scribe. Eric has put into the link, into the chat, a link for you to follow so that you can engage in that. And essentially the conversation is for you to talk about what are the key gaps in our knowledge in the CHWN themes that we're discussing today and sectors. Which of these are the most important to address, from your perspective in terms of like what we need to do first, next, putting a foundation to kind of move our field, accelerate the movement of our field of health workforce science into a space where we're doing and providing a lot more support for the health workforce. So over to you, Eric.
Thanks, Ivy, and hello, everybody. Let me just give you a sense of the trajectory we're going to take over the next hour and a half or so. I've got just two slides. As Ivy says, we're going to now break you into groups in 5 theme areas, and each group will have a moderator and a note taker, so you can sit back and enjoy and talk about the potential research gaps. And they've been given instructions to, first of all, for the first half, do some brainstorming, and then the second half they're going to try to narrow it down to something like 5 to 10 ideas. So we'll come back after a short break around 11:35 and start talking about, as a plenary, go through each of the top 5 to 10 research gaps from each of the 5 theme areas. So the themes, as Ivy says, you've self-selected into these theme areas, and each group has 2 people to support you. What we are going to ask you to do is to join the other platform, which we're going to use for some of the prioritizing. You don't have to join it now, but at some point when you're in your breakout group, you need to join that other platform, because we're going to use it for the prioritizing, and your moderator will explain how that works. So 10:40 here in the Eastern Standard Time. We have about 50 minutes for these breakout groups. As Ivy said, we want you to focus on research-related questions, research-related gaps within your theme area. So Audrey, you ready to open up the breakout groups? And again, the platform is in the Zoom chat. Don't close Zoom because we need it for the audio, obviously. But if you, at some point, if you can join the big long link in the Zoom chat that starts with HTTPS, it will ask you for your name, and you can join the session. But we'll see you in about 50 minutes. Thank you.
Thank you to everybody for your incredible input, your staying power. I'm hoping that you appreciated a break in the middle. We're trying to keep this as human as possible. And yes, we could absolutely talk about this. You know, I could invite you over for the weekend and we could chat about this if we'd like. But you know, we took the time that we had. And I'm hoping that you're seeing my screen, which just are kind of next steps as to where we're going. So some of you participated in our dialogue on Friday. So thank you so much for participating there and today. What came up at that dialogue and also in some of the comments today is that we get prioritization based on the people who showed up. And so to try to address that limitation, we're going to reach out to those who couldn't attend, some people who registered, to add their votes and to add any new ideas. We're going to launch that on July 3rd. If I can get it done any earlier than that, we will get it out. We also want to make sure that survey is going to be available in French because we were only able to do the dialogue in English. And so we want to make sure that we do capture because the Canadian Health Workforce Network is as bilingual as we can possibly be, including the resources. So we will get that survey up and launched on July 3rd. So we're going to be quite selective at who can respond to that. And it's going to be a short time frame. And yes, we know that it's July and some people will be on holidays. But our hope is to be able to get a report back in a timely fashion. We could try to target the end of July. It might go into August, but recognizing that October is the registration deadline for CIHR, you know, we want to make sure that there's availability of these resources for that process going forward. So again, that CIHR, again, such a remarkable investment, including with SHRC, the most that we have seen in health workforce research in my academic career. So again, huge thanks to CIHR for doing that. We want to make sure that we, you know, do the most, like get the best return on our investment to kind of pick up on the last issue that that Lindsay raised just for primary care. So you've seen live results. Éric pulls that together into a cross-leap report. We are going to where the breakout groups were transcribed and we know are recorded. We know that not all of them have been recorded, but we will gather that information to see how that might augment. Nothing is going to be attributed to anybody. So it's a bit sort of Chatham House rules in that sense that we may bring in a quote that was really pithy. If we know who shared that quote, we will reach out to you if you're okay with that. And we're going to integrate that into a report to be forthcoming. So we want this to inform the CIHR process, but we also want to inform our own process at the Canadian Health Workforce Network. And so really want to, you know, to make sure that we're doing the highest quality research going forward. As Rick explained about the Institute for Health Surgeon Policy Research proposal, we are happy at the Canadian Health Workforce Network to be anybody's knowledge mobilization partner on proposals going through. I can say personally, I will not be submitting an application, and in part because I was one of the co-chairs of the Canadian Academy of Health Sciences report of which the call is based. And people may not agree with me, but I see it as potential conflict of interest. And again, we really want to make sure that we're growing this community going forward. So just to let you know about that. So if you haven't yet become a member of the Canadian Health Workforce Network, please do so. It's free. We have resources that we're trying to pull together that could be individually or on behalf of your organization. And so if you look at, you know, about us and organizational members, if you don't see yourself there, please reach out. Again, it's free. And we just want to acknowledge that you have contributed and do work in this area, and you would be identified as a potential partner for grants, whether that's the CIHR call specifically around health workforce. And we also want to encourage everybody to apply for the project grants as well, or to SHRC grants beyond just the investment that has been there in health workforce. So again, just to kind of acknowledge that. And I'm just going to My final comment is just in regards to the Institute for Health Service and Policy research grant that has many other partners on it. We want to make sure that we are supporting our community of organizational partners so that they're not inundated with letters of reference, and want to really kind of have a mindful approach to that. So reach out to us if you'd like to be involved in that, or have any guidance that you'd like to provide. That would be great. So these are all the different ways to connect up with us. And thank you again for all of your participation. Thank you to the scribes, especially folks that came in at the last minute, to our leads who moderated the discussion, pulled together the slides. Thanks to everybody, with a special shout out to Raha and Sophie, to help us, pull the data together for what the CHWN library looks like. And please, please, please send us your resources. Thanks, everybody. Have a great day.